Hi, this is Chris. Welcome back to Basic EKG Interpretation for Healthcare Providers. We're going to go over Chapter 6, Junctional Rhythms now. A quick reminder of the 5 rules, staying with our routine of checking the rate, rhythm, and P waves, PR intervals, and QRS complex width. So, junctional rhythms. What is it? What are they? The junction is the area of the heart that separates the top and the bottom as far as the conduction system. So it's where think of where the atria meets the ventricles. And the purpose of this junction is actually to slow the conduction down slightly. That allows the atria to kick some blood from the top of the heart to the bottom and gives a little bit of time for the ventricles to fill up a little bit more efficiently and make the system work well. So unfortunately, sometimes we can have rhythms that do not originate in the sinus node and they originate in the junction. And because of that, we're not going to get that atrial kick. However, on the bright side, the junction is there as a safety mechanism, if you will. Sometimes it's referred to as a junctional escape rhythm. If the sinus node is not working for whatever reason, the junction takes over. It's a little bit slower. Instead of 60 to 100, you have to remember that the junction is going to be about 40 to 60 beats per minute. And we're also, remember, looking at lead 2. So in lead 2, if we have a junctional rhythm, see how that arrow is pointing up away from lead 2? So what we're going to get, you're going to get inverted P waves in lead 2 before or after the complex. However, sometimes the P wave will occur, you get that atrial depolarization occurring at the same time as ventricular depolarization, so you don't see anything. So here's a few of the things you might see. Your abstract picture over there on the right with a actual EKG complex there on the left. You can have the P wave inverted occurring after the QRS complex where the ventricles actually depolarize first. Again, that's not going to be efficient for kicking blood from the top to the bottom, right? And then you can have a QRS complex with no P wave. So how do we know that this is junctional? Well, because it's narrow, all right? So if you have a narrow QRS complex, we know that it's coming from the upper portion of the heart, somewhere in the atria. And if we don't have a P wave at all, we consider it to be a junctional rhythm. All right, so let's start off with this premature junctional contraction and go through our 5 rules. All right, so measuring the distance between those two look to be identical. All right, and then we have a little bit wider, caliper's got a little bit wider there, and then they become narrow with those 2 particular complexes. So it's an irregular rhythm, but it's regularly irregular. So what I did, I measured the distances in between here, the distances here and there, and I got 19 small boxes apart. So I'm calling this one a rate of 79 underlying, but if we use our 6-second count, it's almost exactly the same at 80, correct? So regularly irregular, and our P waves are normal, except for the early beats. So if you look at all of the P waves that are there, they're all the same morphology, upright and round. All right, and then our PR intervals for all of those are identical as well. So we do have some type of a sinus rhythm here, but we just have these 2 early complexes, right? We don't see a P wave of any sort, so we call it junctional, right? So you have a narrow QRS width of about 0.08. So we're going to call this rhythm sinus with PJCs. I also wanted to point out the reason that you have that a little bit wider caliper. So here and here you can see the wider caliper. This is what's known as a compensatory pause. It allows time for the cardiac cycle to reset. This is a good thing. And so in other words, sometimes these premature beats can be what are called interpolated. They occur early and the heart does not respond with a pause. That can be dangerous and put the person at increased risk of going into a lethal or dangerous rhythm. So our next one is a junctional escape rhythm. Sometimes these are just called junctional rhythms. And however you remember that, just understand that a junctional rhythm is going to be 40 to 60 beats per minute is what we're looking for as far as speed. All right, so first we go through our 5 rules and measure our rate and regularity. Okay, so the regularity is perfect. They're spaced about 30 boxes apart for each one of those R to R waves. So we got a rate of 50 that's regular, and then we have inverted P waves. All right, so all of the P waves are identical going across, but they are upside down, and it is a little bit tight. So you got a PR interval that's definitely less than 0.12. But because they're inverted, that's all the information that we really need. Again, we can measure our QRS width, and we call this one a junctional escape rhythm. All right. If you do have one of these rhythms that's less than 40, you can call it junctional bradycardia. All right. And if it's less than 40, make sure you're checking your patient. That's pretty slow. All right. So the next one is an accelerated junctional rhythm. So if we have a junctional rhythm that is faster than 60, then that's odd. All right, happens all the time, but we expect the speed to be somewhere between 40 and 60 with a junctional rhythm. So if it's faster than 60 but less than 100, we can't call it tachycardia, so we just call it accelerated. All right, so let's go through our 5 rules. And so you can see the regularity is there. The spacing with all those calipers is identical. And so we measure that it's 19 boxes, small boxes apart into 1500, gives us a rate of 79. And the P waves are missing, so we can't measure a PR interval. We can measure our QRS complex width, which is 0.08. So we call this one what it is. It is an accelerated junctional rhythm because it is faster than 60, but slower than 100. All right, it's not tachycardia unless we're faster than 100, which we're going to see right now. All right, so junctional tachycardia. Again, our 5 rules. Measure our regularity. This is a regular rhythm. They are all spaced 12 boxes apart, and that gives us a rate of about 125. You can see with this 6-second strip, it's actually cut off here and here, and that's why it's important for you to understand how to use that 1500 method for counting rate in situations like this. So we can't measure a PR interval because the P waves are inverted and after the QRS complexes, but we can measure our QRS width of 0.08. So we call this one what it is, junctional tachycardia. That is it. I will see you when we get into chapter 7, ventricular rhythm.